All right, so hello everybody. My name is Greg Shemancik. I am Senior Healthcare Analyst within MITRE's Open Health Services Department. I'm also the Deputy Lead for the CodeX FHIR Accelerator, which we'll be talking about today. So basically, we're going to be discussing leaps, bounds, and FHIR accelerators. So really three components of the talk that I want to get across today. So starting off with the first component being the mCODE standard, Minimal Common Oncology Data Elements, which some of you might have heard about. The second component is going to be CodeX, the newest or one of the newest FHIR accelerators that HL7 has introduced. And then the final component is going to be really bringing everything together in discussing some of our current use cases that we're working on. So that's what we're going to be running through today. And so before I really dig into that too much further, I want to really get across the cost of inaction, really what the current state is. Here in America, roughly 40% of Americans at some point in their lifetime will be diagnosed with cancer. And out of those 40% that are diagnosed, only 3% are actually enrolled in clinical trials. And so clinical trials being the gold standard for really learning from and understanding cancer patient treatment. So we have this huge gap in knowledge where we don't really have a learning experience with 97% of the patients that we see. And so therefore we can't apply that to future patients being seen. So a real missed opportunity there. And all of these patients that are being treated have their information captured in one way or another within electronic health records. And of course, these records, these different systems are disparate and far between across different systems. But all the information is there, most likely unstructured in clinical notes, for example. And so we need a way to really be able to get at that information, to be able to apply it to future cancer patients being seen. And so that is where mCODE comes in. So mCODE again stands for Minimal Common Oncology Data Elements, and you can think of it as really speaking the same language when it comes to cancer patient data and cancer patient information. So mCODE is a data standard. It's roughly 73 elements that are really critical to understanding a cancer patient's experience. And so we've worked with a coalition to really build out this set of 73. And I have to emphasize that, of course, it's a core set of information. So it's really what's most critical, what's minimal to understanding the cancer patient journey and being able to learn from that. And so this can be applied to all different types of cancer patients and all different types of electronic health record systems. And so this allows for us to have interoperable data when we're all speaking the same language, again, mCODE being that standard, that language to refer to. And so within mCODE, you have multiple domains that data is actually organized around. So you have the patient, the disease, of course, genomics, the actual treatment of that patient. You have outcomes, which are incredibly critical to understanding really how that patient is doing, and then labs and vitals finally. So I'll focus on one of the domains, outcomes. Being able to understand really how that patient's doing at one point in time, their current status, as well as how they're progressing over time. So cancer progression, disease progression. That's just one example of two elements that we're really focusing on with mCODE that before were collected in structured or unstructured ways. And so that's really critical to understanding the cancer patient's journey. Now, I mentioned that this was really collaboration across a large community, and so we've brought in experts in different areas. ASCO, for example, the American Society of Clinical Oncology, bringing their clinical expertise to bear within the mCODE standard. Ourselves at MITRE bringing our technical expertise and terminology expertise and experience working with Health Level 7. ASTRO for radiation oncology. The Alliance for Clinical Trials in Oncology, focusing on clinical trials, again, that gold standard. The NIH, for example, CancerLink, ASCO's subsidiary. And we don't want to just develop this standard in a vacuum. It has to be piloted. And so we've made sure to partner with folks such as Dana-Farber, Brigham and Women's Hospital, and Intermountain to be able to pilot and really test out our hypotheses here, our standard, to make sure it's airtight and be able to release it so it's reproducible. Logica as well, Health Level 7, and of course, focusing on the FHIR standard, which I'll get to more in a second. And so mentioning that this wasn't just developed in a vacuum, we've had different opportunities to really socialize this, to garner the necessary support around it. So we've hosted events such as the Cancer Data Summit, that we hosted at MITRE down in McLean, Virginia back in October, where we brought in luminaries in the healthcare field, such as the president of the National Academy of Medicine, Victor Zhao, leadership at Mayo Clinic, such as John Halumka, and also the former Chief Technology Officer of the United States, Anish Chopra. So really discussing, how can mCODE function at its best, and also what potentially could even break mCODE, and really critically looking at this element set so that it's airtight. And so, as I've been talking about this element set, you're probably wondering, well, what does it look like? This is the V1, the standard stable version that we're releasing this month for health systems and other developers and implementers to be able to look at and understand the type of data that we're trying to capture and the real potential for using this standard. So that's the first component I wanted to convey, is the mCODE standard itself. And so next we sort of look at, well, how do we organically begin to expand that standard? And so we've focused on partnering with Health Level 7 and their FHIR Accelerator program to bring CodeX, one of the newest FHIR accelerators, to bear, which is the FHIR Accelerator that is focused on oncology. So before I get too much into the organization of FHIR accelerators and of CodeX, I really wanted to touch on sort of where FHIR's been and where it's going. So FHIR stands for Fast Healthcare Interoperability Resources. And if mCODE is the vernacular, really FHIR is the spoken word, really how we're conveying that information from one institution to another. And so FHIR's been leveraged in past accelerators. And again, we have CodeX now working with FHIR as a FHIR accelerator, leveraging this tool to be able to have semantic interoperability. So meaning that not only is the data structured and conveyable, but it's also human readable. It's understood what it is, the information that you're trying to convey. And so now I've mentioned mCODE and FHIR, and really bringing that all together into CodeX, one of HL7's newest FHIR accelerators. So CodeX, again, being oncology focused, is dedicated to basically what we're trying to convey in this hub and spoke model here, which is we have mCODE at the core, and then we're extending its functionality, its capability around additional elements, additional use cases that can then be standardized and then be reproducible across different institutions. So it's really a community. And so you have members that are part of this community, you have folks that are developing and implementing these types of tools. And so it provides that value of areas that you'd like to add interoperability and to automate within your own institutions. And so we have these various use cases that we're focused on. It's a use case forward approach. We have new data models that we can then develop. We have reference implementations and implementation guides that we can then reference and other people can reference as we standardize this information through Health Level 7. So it's going to be readily available, freely available, balloted, commented on, and ultimately proven and released to the public for their ability to consume and to reproduce. And so that's really critical in understanding how we sort of disseminate this standard. Again, we can't just have this be developed in a vacuum. It has to be adopted and used. And so currently within CodeX, we have a base set of founding members. We're lucky enough to work with Pfizer, with EMD Digital. We also have the Alliance for Clinical Trials in Oncology working with us. We have ourselves at MITRE, and then we're working with, of course, Health Level 7 to really found the initial set of use cases, some of which I'm going to be talking about today. We have a number of folks as well that we're onboarding still. And so the community continues to grow. And of course, we welcome new additions as well. And so with our work in CodeX, we've really honed on, in the beginning, a set of 6 different domains that we thought to be critical, that our members and our community has really voiced as critical areas to focus on for these use cases. We started off with, we need to start with just an mCODE basic extraction to be able to harvest those 73 elements and be able to convey that information in a very low burden way. Next, we focused on real-world data. So real-world data in the clinical trial space. I've mentioned briefly how important clinical trials are, and so being able to structure data in a clinical trial setting. Evidence-based care as well. So you can think of clinical decision support, for example. If you're able to basically structure a patient's information, then you can compare that patient to another patient and really judge your outcomes there and what the best practices are for treatment. So number 3 here, patient data management as well. If we're able to structure patient information in a readable way, then we're able to empower the patient as well to be able to have their own information readily available for them and use as they would like. Payment models as well. So naturally, if you can sort of judge outcomes in a structured way and that's readily available, then you can also tie those outcomes to dollars, to payment. And so that's another potential area we've looked into. And finally, something that's near and dear to my heart, which is registry reporting. The reporting process for patient information to registries, be it state registries or other registries, it can be incredibly burdensome to be able to complete these forms, and there's quite a bit of overhead involved as well. So the ability to automate that process has tremendous promise, and I'll be talking a little bit about that in a bit. And one of the last things I really want to touch on within CodeX is how we're really involving the community. So I mentioned our membership, being able to join this accelerator, but one of the last points I'll make is our community of practice, one of our newest additions, which is folks that are able to get involved in a low burden way, to be able to join these monthly calls. It's a monthly call basically where we run through the latest of the CodeX FHIR Accelerator, the mCODE standard, what's being leveraged. Not just updating, but also health systems calling in saying how their implementations are going, what best practices for implementation they have learned, and tying these lessons back in to be able to help support this standard and to help other health systems that are really looking to implement as well, and other institutions. So a multitude of stakeholders working together to bring this standard to bear. So now that I've touched on the mCODE standard and then got into a little bit more about the FHIR Accelerator, really how are we leveraging everything that I've just discussed? What are some use case examples? And so I wanted to get into 2 different examples today that we really think are critical and that we're continually working on now. And of course, these aren't just the only 2 use cases we've had proposed. We've worked across the domains that I previously mentioned. And we had a slew of use cases that we've considered. And I'm just going to really focus on numbers 2 and 5 here. But I'll briefly touch on EHR endpoints for clinical trials. Of course, having information exposed and being able to then structure that information into a clinical trial settings, case report forms, for example, populating those. The data can be incredibly rigorous to collect. Empowering patients to find clinical trials. With that data collected, then are you able to match patients to clinical trials that are appropriate for them? Registry reporting, getting into, again, low burden collection of information and conveying that to registries as needed. Oncology clinical pathways. So as we follow a patient journey, a physician should be able to recommend best practices around that journey. If we're able to structure a patient's information and understand how they're progressing, we can then basically recommend, well, what are next best practices for that patient on their next visit. And so the details of this, what we're really looking to achieve is I mentioned, the actual structuring of patient profiles through case report forms and through the rigorous processes of collecting information within clinical trials. If you're able to structure that information, you're then able to create a sort of ideal patient, a profile for those clinical trials that match the needs of that clinical trial specifically. And so the structuring of information is no longer burdensome, where you have this incredibly rigorous amount of information that needs to be collected for this trial, where you can have patients matched with these patient profiles and then connected to these clinical trials and enrolled. And so it allows for not only structuring of patient information within the clinical trials, but also bringing in new patients to that clinical trial to boost the number of patients that are committed to this gold standard, this learning of how this regimen is performing. And so we have a quick diagram here of sort of how we're envisioning that. We have the provider and the institution they're operating in that's operating this clinical trial. We have the native electronic health record information. We have the information that the patient is bringing to the table. We also have the structuring of this information around mCODE, and specifically mCODE++. So the core standard, again starting with mCODE, but then building out the elements that you need to make this use case happen. And so those additional elements can ultimately be standardized. In this entire use case, the approach that we're testing here can then be reproducible in other clinical trial settings as well. And so you have this patient, this information that is being matched to the eligibility criteria, the ideal profile of this clinical trial. So the final use case I'm going to share with you all today is reimagining CAR-T registry reporting. Now, CAR-T stands for chimeric antigen receptor T-cell therapy, and it's really a groundbreaking type of treatment for a lot of the non-solid cancers you see, such as leukemia or lymphoma, and being able to treat those effectively. For as unique as the treatment is, the actual reporting process for it is also very unique and tends to be burdensome as well. You have roughly 80% of reporting sites for registries that are actually reporting in a paper-based manner the information on CAR-T patients that they are currently treating. And CAR-T as it stands is actually, again, a cutting-edge treatment. And so there are smaller portions, smaller cohorts of patients that are being seen. So any amount of information you can glean is really critical to understanding this treatment. And so the registry reporting process, as burdensome as it is, we're trying to really bring in mCODE, again, leveraging mCODE to collect the necessary minimal set of elements, but also extending beyond that the areas that are really unique to CAR-T, areas such as adverse events. You have cytokine release syndrome, for example, or graft-versus-host disease, which are unique really to the CAR-T space. And so understanding a lot of those adverse events and really understanding the treatment is critical. And so we're lucky enough to be in the process of working with CIBMT, a leading registry, and their reporting sites to be able to basically look at their current reporting practices, make recommendations around how mCODE and extensions of mCODE elements can be implemented. So mapping basically their forms-based process with the current standard of mCODE and what elements are left to really be seen there. Ultimately, basically extending these element sets and then applying that to this use case. So you have the patient and the provider, that interaction. The treatment data can then be surmised from that. We have native electronic health record based information along with the participants' information. And again, the structuring of the mCODE plus data into an aggregated form that the registry is able to collect. So instead of reporting sites having to go through this burdensome form process, they're then able to automatically draw out the elements that are necessary and report those to the cancer registries. And so before I end and as I wrap up, I wanted to get into some final thoughts of really how this all operates together and what we're really driving towards. So I shared that current state in the beginning, that 40% of Americans diagnosed with cancer in their lifetime, and really the gap of information that we have in understanding how best to treat those patients. And this is really an example of the type of system we want to be able to get to, which is a learning health system. The idea that with every single patient that goes through their own cancer journey, we're able to learn from that journey and apply it to future patient care. That's a critical concept to convey. And in order to do that, we need to all be speaking the same language. And while individuals have sort of there are unique areas in healthcare and unique needs within those areas, being able to really rally around a community such as CodeX to be able to bring in the necessary elements, the necessary capabilities to meet all the different needs that are out there. So on a final note, thank you all for joining me here today. I really appreciate your time. And I just wanted to once again convey how critical it is that we have a community organized around this standard and the sort of change that we're trying to see here. So thank you again. I please encourage you to reach out to myself or someone else who's really listed on this slide and to get engaged. So thank you again for your time.